Thank you. Thanks for the invitation to be here. I'm really excited about this program and the ability to interact with my colleagues in the region. If you are a holdover from this morning, you're going to hear some stuff that's a little bit of a redo here, but we're going to try to approach the care of the pregnant patient with congenital heart disease from a physician or a care provider standpoint and explain why some of the pregnancy issues cause such concern. I don't know what happened to the clicker, so I'm just going to use the mouse here. So I have no financial disclosures. So how do we manage a pregnancy complicated by maternal congenital heart disease? Often when we're faced with this in our clinic, we do feel like maybe this is a ticking time bomb. We're very concerned about our patients. And I would approach this as 3 simple steps. First, you need to understand the physiology of pregnancy and delivery. There's no way that you can make an accurate assessment of what's going to happen to a patient and care for this patient if you don't really understand all the changes that happen during normal pregnancy and delivery. Second, you need to be able to define the patient's anatomy completely, and that means you need to be good at imaging and understanding their lesion. And 3, you need to be able to apply the physiology to the anatomy that you're faced with and understand how that's going to interact. And so no matter what the lesion is, if you can do these 3 things, you can manage a patient appropriately and predict some of their risk of complications. So let's first look at the pregnancy and delivery physiology. That's really the key part here. So there's an amazing amount of hemodynamic changes that occur during a normal pregnancy, and it starts very early after conception. So one of the most important things that happens hematologically is that we start to get a marked increase in plasma volume, and that increase in plasma volume continues throughout the entire pregnancy, not at the same rate, but we end up with about a 50% increase in plasma volume compared to baseline by the end of pregnancy. Now, our erythrocyte count does increase as well over time, but it doesn't keep up with our plasma volume, so most of our moms have a relative anemia, as you see here. So what drives this volume expansion? Because this is an interesting question, because we know that not only does volume expand throughout pregnancy, but systemic vascular resistance falls. And it's a little bit contradictory when you think about this. But what we think happens is that early on, after conception, that we have a lot of systemic prostacyclin action and local nitric oxide action that drops vascular tone. So that's how we're going to drop the resistance in mainly the systemic vascular system, but also probably in the pulmonary bed. That drop in vascular tone is going to change your renal blood flow, and your GFR is going to start to go up. Your kidneys are like, whoa, we don't have enough volume. So now they activate the RAS system, and DDAVP starts getting activated. This drives volume expansion. So that part makes sense. But it doesn't make sense that we're going to keep our SVR low because we just activated RAS. So it's very interesting that probably some progesterone action makes our vascular response to the RAS system blunted, so that moms can have their system activated, their volume expansion continues, but they keep their SVR low. And so it's really important for us, especially if we're dealing with moms with different conditions and maybe somewhat in the pulmonary bed, to think about whether our mom will respond to this vascular change to RAS. Will they blunt that or not? So what else happens hemodynamically? Well, cardiac output has to increase. We have to deliver more blood flow per minute. And so if you guys remember from basic physiology class that cardiac output is equal to the stroke volume, how much blood volume per minute or each beat out of the heart times the heart rate. Well, stroke volume is also roughly proportional, if we want to think of this in terms of preload, so it's directly proportional to preload, and indirectly proportional to your vascular resistance. That's going way back to thinking about the Frank-Starling curve. So we know that preload is going to increase during pregnancy. That's that volume expansion that we talked about. SVR is going to decrease. We have nitric oxide and prostacyclins, and then we blunt our RAS response. So now we know that means stroke volume should increase. This is the mechanism. So stroke volume goes up, Heart rate goes up a little bit throughout pregnancy, not a lot. And so cardiac output has a substantial increase throughout the course of pregnancy. And so what that looks like more graphically, as I said, it starts very early. This is not something that happens late in gestation. You really start to take off on your increase in cardiac output right after conception, and you have a pretty steep increase throughout the mid-second trimester. You do continue to increase slightly in the last trimester of pregnancy, but you'll level out a bit. So this is a tremendous increase in cardiac output demand compared to baseline. This is normal physiology. So how does the heart do that? Because if you look at echo studies and you're echoing a mom that's pregnant, her EF doesn't really look any better. So ejection fraction probably doesn't change much during the course of pregnancy. So that's not how we augment this increased stroke volume and increased cardiac output, but we do have important other changes. The left ventricular mass does increase throughout pregnancy, so we have more working cells to increase stroke work. Diastology improves. I think diastology is the key to all of life. I think if we understood this, we would understand so much more about cardiovascular physiology, but we have better diastolic performance during pregnancy, and our LVs tend to become more spherical. So these adaptations occur even if you don't see an increase in ejection fraction. EKG changes do occur, so if you're taking care of a mom, you do expect a small increase in heart rate, but they should not be wildly tachycardic. You might see a decrease in PR, QRS, and QT intervals, but you shouldn't see a change in amplitude, so that would not be okay to suddenly look like you had LVH. That's not a change of pregnancy. You might see a shift of your axis leftward throughout pregnancy. So all of these changes, this increased cardiac output, leads to changes in a normal exam, some things that we'd think were abnormal in a patient that wasn't pregnant. So most of our moms, because of this increased cardiac output, are going to have a soft systolic murmur. The pulmonary outflows, that's usually pretty close to the chest, and we can hear that increased flow out the pulmonary bed. We're going to fill this ventricle rapidly, and we've got great diastolic performance, so we might hear that filling reverberate, and that's an S3. We might hear S1, the tricuspid valve and the mitral valve closure separately because we've changed volume. But it would never be okay if you're listening to a mom who's pregnant to say, well, she has this diastolic murmur, so I think that could just be volume load. That's not going to be one of the changes that we hear. And we should never fix our S2 splitting. It should stay physiologic. You should never hear a grade 3 or greater murmur. That's not just outflow. And an S4 should not be considered normal in most pregnant women. So if we thought the physiology of gestation was impressive, this is a very short time of much more impressive physiologic change, and that's labor and delivery. This is an impressive stress test for our moms. So during labor, we have increased cardiac output demands related just to the energy needed for the act of labor and delivery, but also related to pain and other things. And then we have these rapidly shifting volumes that moms have to be able to accommodate. So every time there's a uterine contraction, we increase blood volume that's in the circulation. And right at delivery, we have a sudden blood loss. Could be up to 1 liter if you have a C-section. And then as soon as they lift the uterus off the IVC, if you're having a C-section, all of a sudden you've got venous return that is impressively increased. So mom's cardiac status has to be able to handle all of these dramatic changes. So now that we know there's pretty impressive change throughout pregnancy, we need to be able to understand our patient's anatomy so that we can then apply our understanding of that physiology. So I would hold out that echocardiography remains the gold standard of evaluation for our pregnant moms. Pre-pregnancy, no doubt, MRI, CT, cath, all of those things help us, as we talked about earlier this morning, making a decision for the patient's status. But nothing beats echo while we're in pregnancy because it's safe, it's pretty portable, you can do it most anywhere, and we can repeat it as often as necessary with really no side effects to evaluate mothers who have hemodynamic changes or concerns that we see in the office. So I think echo remains our workhorse for evaluation and following anatomy changes. So once we know our mom's anatomy, we understand the physiology, let's apply that physiology. So basically, we just need to address these things in our mind as we think about how's our patient going to tolerate this pregnancy. You need to think, how is this lesion going to handle increased volume? In some ways, it might be good. If you have a mom with hypertrophic cardiomyopathy and dynamic outflow obstruction, it actually kind of might like more plasma volume. They get better filling of their ventricle. So if you can say, oh, well, this lesion will handle that well. But if you say, wow, I already have a mom that has a really dilated ventricle from her mitral regurgitation and her LV is already not looking good, she might not like more volume, even though you've probably heard it said kind of cavalierly that regurgitant lesions are easily handled during pregnancy. Then you have to say, can I meet cardiac output demands? Do I have the ability to augment cardiac output? And I think both of the previous speakers show that there's a lot of conditions that we take care of or you can't increase your cardiac output very well. So those are patients who aren't going to handle pregnancy and delivery well. Then you got to think about this decrease in SVR. That's a decrease in afterload. How is mom going to do with that? Some lesions may do well. You may think MR is going to do better with a drop in afterload, and that's probably true if the LV is already still compensated. But going back to our previous example, if you have hypertrophic cardiomyopathy, you might not like a drop in afterload because you might get more dynamic outflow obstruction. So you have to think about this. And then heart rate to some small extent. So there are risk stratification schemes to help us predict cardiac risk during pregnancy for our moms with heart disease, including moms with congenital heart disease. This was the early risk stratification tool. This is from Canada. This is a large group of women, not just with congenital heart disease. And basically, when they followed these women, they found that 4 basic predictors could help us risk stratify them. And the predictors were, did you have a previous cardiac event, meaning a previous episode of heart failure, stroke, arrhythmia? What's your baseline New York Heart Association class? If it's more than 2, that's a risk factor for complication. Cyanosis, that's a room air stat defined in this as less than 92%. Left heart obstruction was a risk factor, and it was not a lot of obstruction, defined as a peak-to-peak gradient across the aortic valve of 30 millimeters of mercury. That's not that much. So some obstruction matters. And then reduced LVEF was defined in this as less than 40%. So if you got a point for each one of these risk factors, you could add those up and predict what the risk of a cardiac event during pregnancy would be, with only one risk factor giving your mom a 25% risk of a cardiac event and greater than 1 risk factor, pretty significant risk. I would emphasize this is not a risk of maternal death, but of decompensation and cardiac problems. The World Health Organization has helped us out with how we should follow moms during pregnancy, general guidelines about seeing them 1 or 2 visits every trimester or more frequently, with the more serious risk class lesions 3 and 4 being seen quite frequently by subspecialty cardiology. And so what are those kind of examples of that? Class 1, a repaired ASD, probably just needs to be seen once or twice, mainly for maternal and obstetrical reassurance. Class 2, unrepaired ASDs and small restrictive VSDs. I think it's somewhat of an argument here that a small restrictive VSD should be class 2, because if there's a reason you haven't gone to the operating room, you're probably not very hemodynamically significant. And interestingly, the Zahara database out of Europe showed that moms with repaired VSDs did worse than moms with small restrictive VSDs. And that's because you already had hemodynamic problems to need your VSD repaired. So I think like anything, there's some debate here. But nobody would debate class 4. Class 4 are moms that we're really, really worried about. We might advise not to have a pregnancy, potentially not to continue the pregnancy, and that would be severe symptomatic AS, severe mitral stenosis, or pulmonary hypertension. A little more extensive risk stratification scheme than the CarePreg group, which is what I first showed. This is a little bit more modern. This is based on congenital heart disease patients. It's a little more complicated. You got all these kind of varying points, and then this is risk. You add up the points, and you can see how many pregnancies in that cohort with that risk factor of points had a complication. So it's not quite as straightforward and easy to look at, but I do want to draw your attention to what drives the risk score. Look at this. Mechanical mitral valve prosthesis, 4.25 points. Right away, you're getting the highest group. One risk factor. And so was so impressive that at this year's International Pregnancy Meeting, we had a large debate about whether mechanical valve prosthesis should be put in that class 4 WHO category of Eisenmenger syndrome, because look at how bad the outcomes were. This is not death, but a complication. And then just taking cardiac medications prior to pregnancy already puts you up into the second risk score. So this is all helpful, and I think it is a good tool for us to help our colleagues and our patients and ourselves understand what we might be facing. When patients present to me for pre-pregnancy counseling, there's a few groups that I would advise to avoid pregnancy, and those are patients with pulmonary hypertension, systemic or subventricular dysfunction where they have significant heart failure symptoms, moms with serious connective tissue disorders and aortic enlargement, and then moms with severe obstructive lesions, mainly on the systemic side, but you do need to consider how they're tolerating PS and TS we don't see too often. So how are we going to manage some of these problems? We've kind of now figured out what's going to happen during pregnancy physiologically, how we've risk stratified our patients. Well, now what are we faced with? Well, we're going to have to know how to use medications appropriately during pregnancy and other options. So the first thing to understand is the FDA classification of drugs during pregnancy. This will freak out your mom or your OB colleagues on some of the meds we're giving if they go and look at this, because basically all of the drugs that we're going to use, unfortunately, are going to be C, D, and X. And that's because either they've not been studied, we're not sure if there's risk, or they've been studied and there is risk, but we've decided that risk outweighs, is not outweighed by the benefit to mom. So there is no one class of drugs that I wouldn't necessarily use by FDA classification. There are X-class drugs that we use with a lot of counseling. So this is just helpful to understand how these drugs got into the classification, but it doesn't preclude the use necessarily. If your mom's already on a cardiac drug, say she's had atrial arrhythmias and she's taking Sotalol or another drug, and you're going to continue that, you need to be aware that there are changes that are going to happen during pregnancy that may make you dose adjust. She's going to have increased cardiac output, so that could change drug metabolism. If the drug is protein bound, there's a drop in serum protein concentration. She might not absorb the drug as well because gastric motility gets messed up. And then she might rev up certain liver enzymes that would drive metabolism. So we need to watch mom's response to drug therapy. Certainly if it's a drug that you can monitor a level, you need to get levels more frequently, even if mom's weight is not changing. There are a few classes of drugs. I said there's no FDA class of drugs that I necessarily wouldn't use, but there are a few classes of drugs that I do always stop because I think there are good alternatives or good reason to avoid for the 9 months of pregnancy. Statins, you might think, gosh, we're talking about a young patient population. Who on earth is using statins? You'd be surprised now of how many moms come to my clinic who are kind of what we consider the older moms, pushing 40. They're now pregnant. They've already either had a cardiac event or they have significant lipid disorders and they've already been prescribed a statin. So that drug absolutely has to stop. I think there's no problem with being off of that for 9 months. I even stop it in my moms who've had acute coronary syndrome just because the fetal effects are so significant. ACE inhibitors and ARBs, they're bad across the pregnancy spectrum, not just in the last trimester and not just in the first trimester. So I think there's good alternatives for those drugs if mom is on them. So I would stop those. Nothing else is on this list for me. Not Coumadin, not amiodarone. All these things I would think about if it had a good benefit to mom. All right, so let's talk about arrhythmias. That's a very important complication in our patient group, whether they're pregnant or not, and it has key implications during pregnancy. So let's look at a case here. This is a woman this is a great story. I saw this woman when I was a fellow in Dallas. And recently she just came back. She moved to Oklahoma. She showed up in my clinic and she said, you were in the delivery room with me, you know, now 13, 14 years ago when my daughter was born. So that was kind of exciting. This is her, 24-year-old woman at the time. Now she's significantly older. She's a DTGA with a mustard or an atrial switch procedure. She's had a long history of flutter, but she's in sinus rhythm on sotalol and DID. She's 8 weeks pregnant. So which of the following do you think is true? It's going to have you raise your hand. That her chance of having a flutter during pregnancy is 10%. That baby's going to be born earlier by chance if she has recurrent flutter. That her previous event of atrial flutter has no predictive value here because we've got her in sinus rhythm. Or that recurrent atrial flutter will not require any consideration of re-echoing her. So what do we think? A, is her chance 10%? Nobody's going to vote, right? Because everyone's too shy. B, got some B votes going. How about C? It doesn't matter now what's going on. D, you guys are on it here. So this is true. B is right. The risk of preterm delivery is increased if she has an episode of recurrent atrial flutter. So maternal arrhythmias are important to fetal outcomes. So moms with congenital heart disease, all comers, not taking into their previous history, they about a 3% risk of a sustained arrhythmia during pregnancy. And unfortunately, any arrhythmia, atrial or ventricular, strongly predicts adverse neonatal outcomes. If you had a previous arrhythmia, as we already said in the CarePreg group, that's a predictor of adverse maternal events. And all comers, if you've already had a cardiac arrhythmia, about a 44% chance you're going to have an arrhythmia during pregnancy. And so I like this little chart here. So if you've had an episode of SVT, about a 50% chance you'll recur. Same with AFib or flutter. This is my favorite, that if you're in atrial fibrillation, pregnancy doesn't cure it. 100% chance you're going to stay in it. And then VT, about a 25 to 30% chance you'll recur. So pretty significant. So treatment of arrhythmias, we really have all the options that we have for a non-pregnant mom. We have our drug therapies available. Cardioversion is an option, and it is safe to cardiovert mom in a life-threatening or hemodynamically unstable rhythm. It's way better to cardiovert her than to let baby be in an environment with poor hemodynamics. Moms can have ICDs implanted. They can wear life vests, and they can receive therapies from those. And that's an important treatment option. So we should not withhold those treatment options if they're important. Now, I don't have a lot of time, and this could take an hour to talk about anticoagulation in pregnancy, but this is the bottom line. There are no good options for anticoagulation in pregnancy, even after all the new drugs that we have available. So there's no perfect option. We do need to know what crosses the placenta for taking care of these moms. Aspirin does cross the placenta, but it is safe even into the last trimester. As long as we're using 81 milligrams of aspirin, we're not probably going to close the duct. Warfarin does cross the placenta, and baby is anticoagulated. Unfractionated and low molecular weight heparins do not cross the placenta. We don't know about the early novel anticoagulants where there's some data that we get some placental crossage. The fibrinolytics or the clot busters probably do cross the placenta. So really we're left with kind of 4 options on a day-to-day management of a mom. We've got warfarin, unfractionated heparins, low molecular weight heparins, or NOACs or DOACs, whichever you feel like calling them. I'll just say right away, we have no information on the novel or direct oral anticoagulants, and right now should not be considered a viable option in pregnancy till we have more data. Sub-Q heparin is a mess, and my advice is don't do that. Sub-Q unfractionated, okay? So we're really left with warfarin, IV heparin, or low molecular weights. So if you're going to use warfarin, ideally your goal INR is 3. This is a hypercoagulable state. You're going to push into a higher INR rate. There may be a decreased risk of fetal effects of changes in their facial structure and bone structure if you can maintain your therapeutic dose less than 5 milligrams. But if your mom is going to be maintained on warfarin, you've got to stop and have a plan for another form of anticoagulation by about 36 weeks because we want to deliver baby unanticoagulated. If you're not going to use warfarin during embryogenesis, first 9 to 12 weeks, some people would argue 9 weeks is the key, you must have alternative monitored anticoagulation strategy. Can't just stop the warfarin and hope for the best in a mom with a mechanical valve. That's a disaster. Unfortunately, you can do perfect management of your warfarin. Mom can come in and have an INR every week, and you can make it perfect, but you may still have increased fetal risk of head bleed or other problems, and that's because the fetal INR is not mom's INR. So you can say, well, INR never was more than 3, but fetal INR, who knows what it was, because there's increased fetal serum bilirubin that has greater affinity of binding the warfarin, so there's more free warfarin available to the fetus. There's reduced metabolism, and they don't have a lot of vitamin K dependent proteins. I'm not going to go through all of this, but unfractionated heparin really should be used more because we're talking about IV heparin. These should be short-term ideas of how you're going to use that. If you do, for some reason, use it long-term, remember that you can get HIT or osteoporosis. Low molecular weights, the key is you got to measure the anti-10A level. Don't wait base. Give this. It doesn't matter what mom's weight if she hasn't changed. You need to get the anti-10A level. So I'm just going to pass through these. This is in your PDF that you'll get, and so will these slides about thromboembolic complications. The bottom line of this meta-analysis is that moms do better on warfarin throughout. Baby has a risk with warfarin, and heparin does a little bit worse with warfarin throughout. So that's the bottom line here. So all those are in your handout. So this is basically the approach. Mom with a mechanical prosthesis, that super high risk group from the Zahara database. If they're not pregnant, you counsel them about risk. If they're going to go ahead, you have a plan. And once they start attempting conception, pregnancy test every 3 days if they miss their period, because you got to get them off the warfarin and onto something else. If they are pregnant and they're taking their warfarin, it's less than 5 milligrams a day, they're therapeutic, maybe you just keep going. That might be the best thing for mom. Otherwise, monitored low molecular weight heparin based on anti-10A levels, week 6 through 12, and then again, week 36 to delivery. So how do we assess babies? We talked about risk of babies having congenital heart disease. That's an important part of our care of our patients to care for our other patient in the room. And so we're pretty good at now at fetal echocardiography, and we should be enthused about doing this because it matters to our patients and their baby's outcome. So if you can diagnose a fetal cardiac anomaly, you improve outcome, and also you make mom feel better if you find out they don't have a condition. So I advise prenatal fetal echo in all of my moms with congenital heart disease. So this just shows that babies do better if we make the diagnosis prenatally. So how do we do that? Well, we look at where is the heart setting in the fetal chest. Is it big? Is it in the wrong section of the chest? How do the chambers look? Are the RV and the LV kind of equal to each other? And then we look at the great vessels. Those are a very important part of the assessment. Is the aorta small and the PA big? That could be a problem. They should be about the same size. Do they have normal crossing anatomy? Then we can look for obvious abnormal anatomic findings, abnormal rhythms, and if the baby has high drops, that's a bad sign that there may be cardiac disease. So this is also going to be in your PDF. We really want to look at this fetal axis of the heart and the thorax, and if you're off axis, either left or right, there's a marked increased risk that you have congenital heart disease. If your heart is big, there's a chance that you have congenital heart disease that's markedly increased. So It is important to remember that fetal circulation is different than adults. So if a baby has an obstruction in the right heart, the left heart gets big. So obstruction in one ventricle leads to contralateral ventricle or vessel enlargement. You want to do side-by-side comparisons and be very careful, and it takes a long time to do these scans. So I just show you a few here in the last minute before the end of the talk. So here's normal. This is normal 4-chamber anatomy. The chambers are all left and right ventricle about equal to each other. The axis looks normal. So this is very reassuring, very simple view. We'd of course look further. Go further here. So here is an abnormal 4-chamber view. This is a hypoplastic left heart. So this is a big right heart and a little bitty left heart there. So that's clearly abnormal. Sorry, I'm not advancing very smoothly here for some reason. So here's another abnormal 4-chamber view. What do you guys think about this? I know I already heard there's pediatric echo guys in the audience. AV canal defect, yeah. And then so here is a normal aortic outflow from the LV. That's one of the things we're looking at when we do the fetal scans. So that's nice to have that. And then there's the crossing PA, and they look about the same size, so that's great. That's normally related great vessels right there. So we can advance here. And so here, unfortunately, is someone who doesn't have the right size. This is the aorta, and it's really small compared to the big PA here in the background. And so that's a bad sign anytime you have this asymmetry, and this turned out to be a complex arch obstruction in this baby. So last few seconds here, genetics are important, but we don't have a lot of great genetic markers for most of our patients with congenital heart disease, with a few exceptions. I think every mom with tetralogy of Fallot or pulmonary atresia VSD should have 22q11 testing done. That's guideline recommendation, and that can help predict whether a baby's going to have a markedly increased risk of defects. Aortopathy patients should be tested. It does matter if you have Loeys-Dietz versus Marfan syndrome. I think that's an important thing to know. And then if you are scanning fetally and you have any defects suspicious for trisomy, you should do fetal genetic testing. So in conclusion, pregnancy is a huge stress test. It takes a whole village to deliver mom and baby safely. So we need all our colleagues involved from OB and maternal fetal medicine and anesthesia and neonatology. And we've got to remember there's 2 patients in the room every time we see them, and we have to make a decision on effects and treatment on both. So thank you for your attention.